Hi, this is Alyssa, Critical Care Pharmacy resident. This clinical pearl will outline heparin-induced thrombocytopenia. So I want to open up with a patient case. This was a 57-year-old male who was admitted to undergo a Whipple procedure. So he underwent the procedure, and postoperatively he was brought to the ICU. On post-op day 1, he was started on heparin for DVT prophylaxis, and then he continued to do well. So a couple days later, he was transferred to the floor. So later on during his hospital course on post-op day 12, patient was noted to have edema of his left arm, and an ultrasound confirmed that he did indeed have a left subclavian and axillary DVT. At the same point in time, look at his platelet trend. So initially it was about 200 when we started sub-Q heparin, and then, about 8 to 10 days later, you should see this sharp decline in his platelet count to about 75. And then this was the point where the patient was diagnosed with the upper extremity DVT. So because of the timing between the heparin and the platelet count and then this new thrombotic issue, this patient was suspected to have heparin-induced thrombocytopenia. So the question then becomes, what anticoagulants are safe to use in this patient with HIT? Can we use enoxaparin, fondaparinux, argatroban, bivalirudin, and then what about rivaroxaban or Xarelto? So I will circle back on this question, but first let's talk about what heparin-induced thrombocytopenia is and what exactly causes this reduction in platelet count in addition to thrombotic complications. So HIT is an immune-mediated adverse drug reaction. It results in thrombocytopenia, but again, that paradoxical prothrombotic state. Incidence is roughly 2 to 3%, and the main risk factor that I want to highlight here is exposure to unfractionated heparin. Low molecular weight heparin, like enoxaparin, can also cause heparin-induced thrombocytopenia, although patients receiving unfractionated heparin are going to be at about 10 times the risk of those receiving enoxaparin. Also want to note that even though the incidence of HIT is relatively low, when you consider how many patients each year are exposed to heparin in the hospital setting, this leads to a substantial number of patients who do actually develop heparin-induced thrombocytopenia. So it's relatively rare, but it definitely is something that we see. And if it's left untreated, HIT is associated with up to a 10% daily risk of thromboembolism, the need for amputation due to limb ischemia, and ultimately, it can be deadly. So it's important that we recognize and treat HIT immediately. Patients present with thrombocytopenia. Typically, the nadir or the lowest platelet count that they get to will be in the range of 40 to 80. A typical onset would be 5 to 10 days following the heparin exposure when the patient would develop thrombocytopenia, although it can actually occur within a day, so it can be rapid onset if the patient's been exposed to heparin within the last 30 days. About 50% of patients with heparin-induced thrombocytopenia will develop thrombosis. Most commonly, this is venous in the form of a DVT or a PE, although arterial thromboembolic events can also occur. And when we look at what causes the thrombocytopenia and the clot, this really explains it all. So first of all, we need exposure to heparin or low molecular weight heparin, which is a negatively charged compound. We also have PF4, which just circulates around in the bloodstream. So platelet factor 4, it's a positively charged protein released from platelets. So together, the two bind and they form a complex. The immune system can potentially recognize this complex as being foreign, in which case we produce antibodies that bind to the complex. These antibodies also bind to the platelet via the Fc receptor, and when this binding occurs, that's what causes that prothrombotic state. So we end up with platelet activation and aggregation. We release more PF4, we release procoagulant microparticles, and we generate thrombin. So our platelets are basically being chewed up in this clotting process. So when we look at treatment, obviously stop all of our heparin products because that's what caused this in the first place. The pharmacist should also be responsible for marking heparin as an allergy to make sure that the patient does not inadvertently receive heparin products. Step 2 would be to start a non-heparin anticoagulant because again, even if the patient doesn't have a confirmed clot yet, with having HIT, they'll be at a much higher risk of developing a clot. And then lastly, there are numerous things that can cause thrombocytopenia, so we should always do lab testing to either confirm or rule out the HIT diagnosis. If HIT is ruled out, if the testing comes back negative, we can actually just start the patient back on heparin. If the testing is positive, then we need to continue down this route of non-heparin anticoagulants. So the non-heparin anticoagulants we can use, first of all, are injectable agents. We have our direct thrombin inhibitors, argatroban and bivalirudin, and then fondaparinux, which is our factor Xa inhibitor. The most common one that you'll see in the ICU setting, and the one that I'll focus on here, is argatroban. So argatroban, a typical starting dose in the ICU is 0.5 micrograms per kilogram per minute, and we might even choose a lower dose if the patient has significant hepatic failure. The half-life is relatively short, so patients should be at steady state at roughly 3 hours when they're on argatroban. So monitoring will be via the APTT, or the activated partial thromboplastin time, and we'll check the first APTT 3 hours after the argatroban infusion is started. We'll continue checking the APTT every 3 hours and titrating appropriately until we have 2 levels within range, at which point we can back off to monitoring the APTT once a day. So it's basically the same thing as monitoring heparin with your anti-10As. Bivalirudin is essentially the same when it comes to monitoring. Again, it's got a short half-life, and it is prolonged, however, in renal impairment. Fondaparinux is also another option. This is a subcutaneous injection. It's given once a day. The convenient thing with fondaparinux is that there's no lab monitoring needed. However, fondaparinux should not be used in patients with renal impairment, which does tend to become a problem in our critically ill patients. On the oral anticoagulant side, both apixaban and rivaroxaban are potential options for heparin-induced thrombocytopenia. These are direct oral anticoagulants, and they act by inhibiting factor Xa. Nice thing about these is that there's no routine monitoring needed, and obviously they're oral medications, so it's easy to send a patient home on these. Another advantage is that these medications work right away, unlike warfarin, so we can honestly start the patient on these medications right off the bat, or if we'd prefer, we can start them on one of our IV or subcutaneous medications first, and then later on transition them to either Eliquis or Xarelto. Warfarin was pretty much the mainstay previously before apixaban and rivaroxaban were available, but no longer is it really our medication of choice. First of all, warfarin can never be used in acute HIT, so we always need to wait until a patient's platelet count has recovered. The reason for this is that warfarin takes several days to work, and before its anticoagulant effects become apparent, it actually wipes out our body's natural anticoagulants, so it can lead to an increased risk of clotting or a transient prothrombotic state. When we already have a patient with HIT, we would just be exacerbating that. So for that reason, we wait until the platelet count's recovered, and then we also need to overlap warfarin with parenteral anticoagulant for at least 5 days. Oftentimes, we'll start a patient on argatroban, and then we'll transition them over to warfarin once their platelet count has recovered. And this is logistically challenging because argatroban actually has a lab drug interaction where it increases the INR, and it roughly doubles the INR compared to what the patient's true INR is. So once we start warfarin, we overlap for at least 5 days. Hopefully by day 5, we actually want that patient's INR to be at least 4. So once our INR is at least 4, we can go ahead, stop the argatroban, wait about 4 to 6 hours until all of the argatroban is out of the patient's system, and then we can recheck the INR. And at this point, we are hoping that our INR is at least 2 in the absence of argatroban, so we can say that the patient is therapeutic on warfarin alone. So if our INR is at least 2, then we can go ahead and leave the argatroban off and just continue warfarin. But if the INR is less than 2, then unfortunately we need to restart the argatroban drip, continue dosing warfarin, and try this whole process all over again the next day. So if you do have a patient where you're transitioning from argatroban to warfarin and you have any questions about that, feel free to reach out to your pharmacist and we are happy to help. So circling back to that question, what can we use for HIT? So we cannot use enoxaparin because it's a low molecular weight heparin and it has the potential to cause HIT, but we can use fondaparinux. We could use argatroban, bivalirudin, and then rivaroxaban and apixaban are also potential options. If you have a patient who's unstable and in the ICU, we might want to go with argatroban or bivalirudin because they have a short half-life. So if we need to stop anticoagulation for whatever reason, the patient's bleeding or if the patient needs to go to surgery, then we can go ahead and do so, and these will wear off fairly quickly, where we don't have that option with fondaparinux or rivaroxaban. So in summary, HIT is an immune-mediated reaction. It results in both thrombocytopenia and thromboembolism. And if you have a patient with suspected or confirmed HIT, stop heparin products, use non-heparin anticoagulants, and as always, monitor for signs and symptoms of thromboembolism and bleeding. And that concludes my little quick and dirty pearl on heparin-induced thrombocytopenia. If you have any questions or comments, please feel free to reach out to me. And thank you so much for listening.